Namaskar and hello and hi to everybody wherever you are. So we are into our 335th webinar from our forum Young India Intensivist, and we have these from our best of national faculty, but on and off, wherever is possible, we try to get the best experts from across the world, from America, from Europe and other parts. So today we are indeed honored, and it's a great pleasure to have a great expert from Harvard University, Harvard Medical School, whatever you want to call it, the Mecca of medicine, Dr. Tyler Peck. Dr. Tyler Peck is extremely, versatile in this particular topic, cardiovascular physiology in the ICU. And I think it will be a great learning for all of us on this topic, that is the left ventricle and the systemic vascular resistance. We have covered certain other aspects. We had Dr. Waxman, again from Harvard. He talked about the right ventricle and the pulmonary arterial hypertension status in these patients. And we covered cardiovascular dynamics in sepsis, etc. We'll be doing guidance physiology, the venous returns, and other concepts also. So I will not take too much of your time, Dr. Peck, and hand it over to you. Please teach us, let us go through this. Thank you very much.
Well, thank you so much. It's a great pleasure to be here with you all. And I think we'll dive right into this topic on cardiovascular physiology in the ICU, focusing on the left ventricle and the systemic vascular resistance. I have no disclosures or financial conflicts of interest to disclose for this talk. So heart failure is an important concept in the ICU, and it has a major impact on our patients. From some kind of focus studies and meta-analyses, we know that about 20% of hospitalized heart failure patients do require ICU level care due to heart failure and related conditions. The in-hospital mortality for heart failure patients admitted to the cardiac ICU is reported at 12.5 up to 29%, pretty exceedingly high for patients who are admitted with that diagnosis to the ICU. And patients who are admitted to the ICU after an initial delay period in which they are not initially triaged to the ICU have the highest risk. They have a 30-day mortality hazard ratio close to 5 compared to ward-only patients. And we know that the cost is higher to care for these patients as well. So in jumping right in, the outline for today's session is I'd like to talk a bit about just the physiology and pathophysiology behind left ventricular failure and talk about the hemodynamic derangements that occur in that state. We'll talk about how best to assess hemodynamics in the ICU, and that's both non-invasively and invasively. We'll talk about hemodynamic phenotypes in left ventricular failure and how to stage left ventricular failure and cardiogenic shock. We'll talk about management strategies for this condition. I'll talk a bit about monitoring and targets for our care in the ICU for heart failure patients. And then we'll talk about future directions and controversies before we summarize. So to start, the definition of heart failure is a bit different from cardiogenic shock, just to be clear on our definitions. So acute decompensated heart failure may require hospitalization or may require inpatient care, and is the rapid or gradual worsening of heart failure symptoms, typically in the setting with congestion on physical exam, volume overload, weight gain, in the setting of pre-existing heart disease. And it can be triggered by anything from acute myocardial ischemia to arrhythmias. Perhaps patients have newly developed atrial fibrillation, uncontrolled hypertension, infection. So there's a long list of things that can contribute to this decompensated state. But it doesn't necessarily mean that the patient is in shock whenever they're in decompensated heart failure. It just means that they are in not a well-optimized state and require some attention to their care. Cardiogenic shock, however, is when there is a critical reduction in the cardiac output resulting in end organ dysfunction due to that cardiac failure. And that can lead to hypotension, hypoperfusion, elevated cardiac filling pressures, which we'll talk more about filling pressures in the coming slides. And this, as opposed to decompensated heart failure alone, cardiogenic shock is a life-threatening emergency. These patients are not perfusing well, and it really requires a structured approach to their care to best care for them. So I'd like to include a case with this discussion. We have a 68-year-old female, history of insulin-dependent diabetes. She has hypertension. She's a longtime tobacco user, and she presents to the ED with chest pain for the last 2 days. Her EKG in the emergency department reveals anterior ST elevations in that region, and she's taken promptly to the cardiac catheterization lab for what's felt to be an ST elevation myocardial infarction. She, on coronary angiography, is found to have severe multivessel coronary disease. No percutaneous coronary intervention is performed because of the multivessel nature and some difficulties with her anatomy. So they did not perform a coronary intervention at this time and plan to admit her to the ICU with planning for a future procedure if possible. The patient has hypotension and concerning for shock. And so the patient is started on norepinephrine up to 0.3 nanograms per kg per minute, or micrograms per kg per minute, that slide should say. Vasopressin, 0.03 units per minute. And these are both for hypotension. A cardiac POCUS, or point of care ultrasound, is attempted, an attempt to get an idea of how the LV function looks. And we'll show this clip. This is a parasternal long axis view with the left ventricle noted in the bottom left part of the screen. And you can see that the LV wall, the left ventricular wall, is quite hypokinetic. The mitral valve apparatus here, the anterior leaflet of the mitral valve, is not moving quite as we would expect, where it moves much more towards the septum during diastolic filling of the left ventricle. So there's a significant amount of dysfunction here. So the case continues. The patient was intubated and placed on mechanical ventilation during the procedure for altered mental status. And they're admitted to the ICU with the vital signs you see listed here. They do have borderline hypotension with blood pressure of 82/63, MAP of 69. They're oxygenating well on their current ventilator settings. And you see the labs listed here that the lactate is elevated to 5.4 millimoles per liter, and the arterial blood gas shows a primarily metabolic acidosis with adequate oxygenation. So we'll step away from our case for a moment, leaving our patient acknowledging that they're in what looks to be cardiogenic shock, but we have more information to find out. So the pathophysiology and hemodynamic derangements, we want to really talk about and highlight clearly here. So when we talk about cardiac output, that is the output in liters per minute from the left ventricle or from the heart in terms of its pump function. But that output is governed by 4 key factors. We have preload, which is kind of the filling of the cardiac chambers that provide the substrate for the heart to then pump forward. We have afterload, which is the kind of mechanical load on the backside, or the after, the kind of the post pressure on the pump itself on the left ventricle. In this case, that would be kind of the arterial or aortic pressure on the left ventricle. Contractility also contributes to cardiac output. That's the actual kind of squeeze function of the left ventricular muscle, contributing to what's called stroke volume, which is the amount of blood, typically measured in milliliters, that's pumped out with each contraction. And then we have heart rate, which contributes to the cardiac output. So we typically think of cardiac output as being calculated by that stroke volume of how many cc's per squeeze that we get from the left ventricle, multiplied by the heart rate in beats per minute, so that we get cc's per minute, which can be converted to liters per minute. So in this case, we have a diagram here that shows that the left ventricular is filled from the left atrium, from the pulmonary circulation. It has certain intrinsic contractility, and it has its electrical discharges contributing to the heart rate. And then that output is also impacted by that afterload, the pressure after the ventricle, which is contributing to that, the ability for the left ventricle to produce forward flow. So one of the central concepts in critical care is this idea that the stroke volume or the amount of output, the cardiac output, can increase with increasing filling pressure. So you see on the y-axis here, stroke volume, like we just talked about as a kind of a measure of contractility. And then we have on the bottom, either the left ventricular end diastolic pressure or the end diastolic volume. So how well the left ventricle is filled at end diastole. And so the solid curve, or that number 1 dot, is kind of a typical heart, normal left ventricle, in which as you increase the load, the end diastolic load on the left ventricle, you have an increase in the stroke volume. So the patient may receive some additional fluids as part of their resuscitation as they're admitted to the ICU with hypotension, and their cardiac output, their stroke volume actually goes up as they move towards the right on this curve. So their stroke volume increases as their filling pressure increases. The difficulty with left ventricular dysfunction is that many patients start out with a high end diastolic volume, a high end diastolic pressure, and they have a limited ability to augment their stroke volume or their contractility, augment their cardiac output with increasing filling pressures. And so as you see in the dotted line at the bottom, we have dot number 2, in which the patient starts out at a relatively high filling pressure. If they were to receive additional fluid, or if they were to be loaded additionally with preload, they would not increase their cardiac output any further, which is the difficult thing with our cardiogenic shock patients, in that the kind of one of the more common interventions that we provide for patients with shock, administration of IV fluids, does not produce an increase in the cardiac output, which is contributing to their shock state. And so that's one of the difficulties of this situation. So I always like to think about this in terms of pressure volume curves, and we'll kind of talk through this because I think it's a relatively important concept to understand. So if we think about how the heart fills, it cycles in this counterclockwise motion around this pressure volume loop. So as the left ventricle relaxes, it starts out at a relatively low volume and a low pressure. The mitral valve opens, there's diastolic filling, the volume increases. The pressure has not yet increased significantly because there's relatively low pressure filling that is occurring in the left ventricle. But at the time that the mitral valve closes and the left ventricle starts to contract, you have what's called isovolumetric contraction, in which the volume is the same, but the pressure increases greatly as the left ventricle wall squeezes into that left ventricular cavity space. At the time of the continuation of the contraction, the aortic valve opens. You start to have systolic ejection of that stroke volume into the aorta. And so you can see that our volume starts to decrease or move leftward on the chart, but we do have also a rise in pressure as that blood is leaving the left ventricle. And then the aortic valve closes and the process starts over again. The pressure quickly drops, and you return to that diastolic state in which the mitral valve opens and you have diastolic filling. So the reason why this is helpful to think about is that this phenomenon can be measured with a left ventricular catheter. We don't commonly use it in the ICU, but it can be done in the catheterization lab or in specific kind of study states. And so we can see that patients who have left ventricular failure start to have kind of a rightward shift of this curve where they have increasing volumes. And then particularly as their contractility decreases, their stroke volume, this kind of difference between a full left ventricle and an emptied left ventricle, starts to narrow, and the pressure that they generate is not quite as high. So we'll show a picture of that in a moment. We have a couple of additional measures that we can obtain from this graph, which includes the concept of the end-systolic pressure-volume relationship, in which this is a charted table across a number of these cycles where we are kind of fixated on this point where the the aortic valve has closed and we have an in-systolic pressure before the left ventricle relaxes. And it gives us a sense of like the elastance of the left ventricle itself. And so how much kind of squeeze and how much like inward force there is. As a measure, and that's a kind of a description of the contractility of the left ventricle. The arterial elastance, however, is this slope that's graphed from the same point down to the zero pressure point in diastole. So this place where the ventricle is fully filled but fully relaxed and at low pressure. And so this is a kind of downward slope, and that gives us an idea of the elastance of the arterial system. So like what elastance or what is the kind of pressure shift that is created in the arterial system as you have kind of pressurized the ventricle and are ejecting the stroke volume of blood into that system. So these typically are at a ratio of 1 and are kind of at a similar angle, even if in opposite directions, is kind of a normal slope for those two curves. So in this graph, this is another representation. We see kind of a range of these pressure volume loops for the heart in various cycles, and we get a nice graph of that in-systolic pressure point across a range of cardiac cycles. And so the slope of that is this in-systolic left ventricular elastance. And then you can see here graphed on kind of a normal left ventricle, you can see that the arterial elastance meets the in-systolic LV elastance well. So those things are matched. In various heart failure states, this is abnormal. So as I mentioned before, we'll focus on the heart failure with reduced ejection fraction. We see a rightward shift with an increase in the systolic and diastolic volumes of the left ventricle. Overall, we see a bit of a decrease in the amount of pressure that can be generated by a poorly contractile left ventricle, and we have a relatively narrow stroke volume. What I want to highlight here is that the arterial elastance is in this slotted or dotted line. We see that the slope is relatively steep compared to the low slope of this in-systolic left ventricular elastance. So if we were to provide some intervention that reduced that LV afterload, reduced that arterial elastance, kind of the squeeze of the arterial system against a forward flow of volume, and that would be represented by a kind of a decrease in this slope so that it is now at this kind of reduced angle. That is a relatively small reduction in the elastance. You can see that the stroke volume has actually widened quite a bit and has increased by 23 milliliters. So this is what is happening on the left ventricular physiology level whenever we provide afterload reduction. So we reduce the arterial elastance for our patients. We can produce this shift that increases their cardiac output. Hopefully this concept is helpful in thinking about LV physiology. We'll continue kind of forward with our talk. I'll say that arterial elastance is only one of the measures that we use to measure the LV afterload. And the one that you may be much more commonly accustomed to is the systemic vascular resistance, which you see here. I'll say that the arterial elastance and the systemic vascular resistance are relatively kind of static, and particularly the systemic vascular resistance is measured in this kind of static, steady state where we kind of have fixed specific pressures that we use to calculate it. We'll talk about that more in a moment. But the LV afterload is this complex interaction between the static pressure in the aorta whenever the aortic valve opens, that afterload that is pushing against or resisting flow out of the left ventricle. But you also have a pulsatile component to this. And there's also an interaction of flow waves where there's a forward flow and how well the aorta conducts the forward pulse of blood out of the left ventricle. And then we know that there is a reflection, which we think of as also being seen in the dicrotic notch if you're looking at an aortic or an arterial pressure tracing. So you can see that there is complexity to this interaction. So whenever you're thinking about your patients, it's a little bit more complex than what we always have the tools to look at the bedside. But we can kind of simplify it in these ways as long as we understand the limitations. So to talk about the systemic vascular resistance specifically, because it is one of our more common measures of LV afterload, it's accessible because if we have a limited number of variables, we can calculate the systemic vascular resistance. And that's calculated using the mean arterial pressure, subtracted, and you subtract the central venous pressure, or the right atrial pressure, and then you divide that difference by the cardiac output. And so you can obtain these variables in a pretty straightforward fashion, many times with a pulmonary artery catheter, which we'll talk about more later. And the number that you get from this calculation, you multiply by 80 for a conversion to convert to the standard unit, which is dynes per second per centimeter to the fifth power. The typical range for systemic vascular resistance is measured between 80 and 1200. It is common for patients who have cardiogenic shock as a compensatory mechanism whenever the left ventricular output goes down to have a rise in their systemic vascular resistance to try to maintain a perfusing blood pressure. So as the output from the left ventricle decreases, you have a squeeze of the systemic arterial tree that causes there to be kind of further increase in afterload. So while it's adaptive to try to increase the pressure, it can be a further resistance or further increase in the left ventricular afterload that causes there to be less forward flow, which is just a difficult concept and something that we address when we're thinking about taking care of patients with left ventricular failure in the ICU. So to summarize this a little more clearly, we think about this concept of ventricular-arterial coupling whenever we're thinking about good function. The left ventricle squeezes, the arterial tree can accommodate that forward flow or that stroke volume. But in left ventricular failure, you start to have this decoupling in which the contractility of the left ventricle decreases, the systemic vascular resistance increases, and as a result, the ventricle actually has to work harder for less stroke volume, which just leads to this cycle of inefficiency and worsening failure. We see that here because as the compensatory vasoconstriction, which you see in the bottom right, increases, the afterload starts to increase, the systemic vascular resistance is increasing, the workload and the oxygen demand of the left ventricle increases. You have further decrease in your cardiac output. Again, this poor efficiency where the O2, our oxygen demand is increasing, but your cardiac output, your stroke volume is decreasing. And then in response to that, you have further vasoconstriction. So it's this vicious cycle of altered systemic vascular resistance and left ventricular failure. So we'll shift away from that pathophysiology thinking to go back to our case. So we left our patient, they were admitted to the ICU with shock. They remained on moderately high dose of norepinephrine with vasopressin. Right now, their blood pressure is 95/72 with a MAP measuring, the mean arterial pressure measuring at 80. Their lactate does remain elevated at 6.2. And as a team, we are thinking about this concept of increased afterload, which may be decreasing our cardiac output and contributing to shock. And so we've talked about reducing that target MAP, really targeting specifically a MAP of 65, rather than allowing the patient to remain at a higher MAP of 80, in hope that kind of decreasing that LV afterload, that left ventricular afterload, will bring that patient to a better place in terms of their cardiac output. So on follow-up, the patient has labs an hour or two later, you see that the lactate is downtrending, which is reassuring. So now we'll talk about hemodynamic assessment in the ICU and focusing on the left ventricle. So the goals of our hemodynamic assessment are to determine the phenotype of our patient's left ventricle failure. Is the patient wet or congested or volume overloaded, in other words? And are they cold? Are they having poor perfusion? When you feel their extremities, when you feel their skin, are they having adequate flow to kind of maintain that temperature of the tissue? And so we're worried if patients are really congested and really cold and not perfusing well. So we want to find those patients quickly. We want to quantify the problem. We want to find out what is the cardiac output, what do we think the systemic vascular resistance is, what do we think the failing pressures are, and we can talk about ways to estimate those or measure them directly. We want to assess our hemodynamics to guide our therapy and provide real-time, feedback on interventions if we can kind of follow up with some of this testing after we make changes to the patient. And then we want to stratify the patient in terms of their risk of further decompensation or need for escalation of therapy. So the first rule of medicine is always to look at your patient first. We like to look for signs of hypoperfusion. That includes just feeling for cold extremities, as I mentioned before. It may be that cold hands or feet are just really an indicator that there's bad flow or poor circulation to the limbs. Obviously, this can be limited in patients who have peripheral artery disease or have other reasons to have, cool extremities. But, for many patients, you'll find that, either their feet or the backs of their knees or, other parts of their extremities are just cold to the touch. And that can be a representation of that increased systemic vascular resistance or clamped down peripheral circulation that's not allowing forward flow. We also can see that the patient has just poor perfusion of their end organs, and that can produce low urine output or oliguria, and that's because of inadequate kidney perfusion. And then also altered mentation is another signal that the patient may be hypoperfusing. Obviously, there's a lot of reasons why our patients in the ICU can have encephalopathy, but one of the four most reasons in particularly the cardiac ICU is that they may just simply not have enough forward flow to their brain to perform a stable function of cerebral function. So that can be an early sign that the patient has reduced cardiac output and is in shock. There are a couple of different ways that we can more kind of objectively measure these variables. So that includes something called the pulmonary artery catheter, which is a catheter that's placed into the venous system, the central venous system, typically through the right internal jugular vein or the left subclavian vein. That catheter has a balloon on the tip. We'll talk about this in a moment, but it's advanced into the pulmonary artery. We can measure variables, including cardiac output through a couple different measures. We can measure PA pressures, and we can also measure the filling pressures of the left ventricle and the right ventricle. Those are the proxy measurement of the left ventricular filling pressure is this pulmonary capillary wedge pressure, which is a surrogate for the left atrial pressure, which gives us an idea of the left ventricular filling pressure. We can also measure something called the mixed venous oxygen saturation, or the SVO2, where we're getting that PA, the pulmonary artery oxygen saturation, which we can look at in and of itself to guide us about in terms of kind of the patient's oxygen consumption and that contributing to their cardiac output calculation. We can also use the Fick equation to actually calculate the cardiac output if we have a few other variables. So this is really comprehensive. It's the gold standard in terms of monitoring, but it is invasive. It's operator dependent. The bedside intensivist needs to be able to place this catheter, and there can be complications like infections, pulmonary artery injury, and just procedural complications. So we are thoughtful about when we place these catheters. You can consider, and it's certainly become more common in medicine, to use point of care ultrasound or echocardiography to look at the left ventricular function. You won't necessarily have a direct measurement of the filling pressures. You won't have a direct measurement of the cardiac output, but you can get a overall sense of how well the left ventricle and the right ventricle are functioning in terms of their squeeze or their ejection fraction. You can measure the volume time integral across the aortic valve, for example, to give you an estimate of the cardiac output. Non-invasive and has some limitations, but can be a good measure of whether you think that the cardiac output is normal versus severely reduced. The nice thing about these measures is that they're non-invasive and are relatively quick to perform at the bedside, but it does require some of that extra skill. You have to be trained in cardiac ultrasound to be able to maintain or obtain some of these advanced measures. And then lastly, and probably less commonly, we do occasionally use arterial line waveform analysis, where we're using the arterial actual waveform on our monitors to get a sense of the cardiac output. And this is continuous. It can be measured on our monitors, but it does require specific hardware to be able to perform this. So not always the most practical, but is another option in terms of assessment. So going back to the pulmonary artery catheter, which again is our gold standard, it's this invasive test. You see a picture of the pulmonary artery catheter on the left side of the screen. It's a long catheter, typically coiled, and we kind of maintain that coil to direct the tip of the catheter through into the right atrium and through into the pulmonary artery. It's placed through a venous introducer, which is placed again into the either typically the right internal jugular vein or the left subclavian vein. And then that curve, with the help of a balloon tip, passes through, as we see in the pictures here, through the right atrium, ideally through the right ventricle, into the pulmonary artery. And then you can also obtain this pulmonary artery wedge pressure that we talked about, which is a proxy measure of the left atrial pressure and gives you an idea of the left ventricular filling pressure. If you do this without fluoroscopy, you can see a shift in the pressures on the monitor. And so you can see that the right atrial pressure is relatively low in a normal state. You start to see pulsatility whenever the catheter tip enters the right ventricle, but the diastolic pressures remain low. One of the hallmarks of knowing that your catheter has passed into the pulmonary artery is that you have a diastolic step up, in which past the pulmonic valve, those diastolic pressures go up higher. And then whenever you've achieved an adequate pulmonary artery wedge pressure, you'll see that the pulsatility decreases and you start to have a much more kind of flat tracing. So the normal pressures are listed here. You see that the right atrial pressure is kind of the lowest pressure in the system. It's the pressure step up occurs in the systolic pressure as you step into the right ventricle. You pass the pulmonic valve, a normal pulmonary artery pressure is 20/10 or so. And then your left atrial pressure, or your wedge pressure, normal range is kind of that 3 to 12 area. And then you have, again, a large systolic step up whenever you step into the left ventricle, again, pressurizing so that you can achieve those forward flows against the high aortic pressure. And so we have these hemodynamics that we keep in mind whenever we're placing a pulmonary artery catheter. And certainly whenever you are looking at the filling pressures, which we typically are thinking the right atrial pressure is the filling pressure of the right ventricle, that left atrial pressure, or the surrogate, the pulmonary capillary wedge pressure, is this filling pressure of the left ventricle. So as those are rising above these two values, particularly when we're thinking about left ventricular failure, if your wedge pressure is rising, abnormal would be above 15, you are feeling that the left ventricle, for some reason, is having some impaired filling and impaired forward flow potentially. Of course, that can be potentially altered by mitral valve stenosis, severe mitral regurgitation. So there are a few situations where the left atrial pressure may be high without impaired left ventricular function. So when we think about the hemodynamic profile, looking at pulmonary artery pressures or pulmonary artery catheter pressures and flow measures on our monitor or in our ICU, you'll see that there are some specific profiles related, to left ventricular function where we can see changes. I'll focus in on cardiogenic shock. As we've already mentioned, the pulmonary artery wedge pressure here will go up when the left ventricle is failing. And so that is because there's poor forward flow, and the left ventricular filling pressure goes up as the left ventricle is struggling to function. The cardiac index is the index for the patient's body size. It's an index measure of the cardiac output. And so that will decrease classically in cardiogenic shock. And then also you will see a decrease in the right ventricular function as well, just as a compensation for the left side failure. And so we see that the pulmonary artery pulsatility index can also go down as your cardiac output overall is decreasing. There are a lot of measures here where you can see how helpful a pulmonary artery catheter can be in parsing out kind of overt cardiogenic shock, for example, from chronic heart failure, where maybe the index or cardiac output is relatively the same. You may have some rise in the filling pressure or the pulmonary artery wedge pressure just because of that chronic failure, but the function or the forward flow out of the left ventricle is not severely reduced. And, for example, your pulmonary vascular resistance may be about the same. That applies more to the right ventricle. So there has been an evolution in the role of the pulmonary artery catheter in the ICU in general. It once, 20 years ago was ubiquitous, at least in the United States, and was very much used commonly to define shock hemodynamics for our patients, in the hope that we, by identifying these shock parameters, would be able to target specific therapy to try to move patients forward. But trials have shown that routine use does not improve outcomes. for all-comer ICU patients. And so we have really backed off on the use of pulmonary artery catheters, but not in a way that pulmonary artery catheters are not helpful. It's just that we really try to focus in on hypothesis-driven use. And so we're selective for patients who have specific characteristics of their shock that we either don't well understand or look very much like cardiogenic shock in a way that we really hope that the pulmonary artery catheter can drive our care forward or drive our management forward. So that can be when the hemodynamic picture is simply unclear. As you well know, patients in the ICU can have overlapping phenomena, including sepsis, heart failure, vasodilation related to other states like cirrhosis, for example. So it can be really complicated understanding what the patient's hemodynamics are. And in those cases, a pulmonary artery pressure catheter may be helpful. I find it helpful whenever I think that the patient may have, distributive shock or may have a component of cardiogenic shock, but I'm trying to use therapies that I think will help the patient, but the patient's just simply not responding in the way that I expect. So that can be a helpful situation to use it in. Certainly for patients who have potential pulmonary hypertension or may have impaired right ventricular function, a pulmonary artery catheter can be helpful in defining their pulmonary hypertension, diagnosing them, and then giving them phenotypic data so that we can think about how best to treat them or manage their pulmonary hypertension. And then pulmonary artery catheters, lastly, can be very helpful in defining when a patient may simply need mechanical support for their failing left ventricle to get them better. So the point of care ultrasound, as I mentioned, can be a helpful tool to the intensivist. See if I can get this. I think it will continue to move. So the left ventricle, as you see here, this is a parasternal short axis view. You can see that the papillary muscles from the mitral valve apparatus, and you can see that concentric ring of the left ventricle is simply not squeezing well. So we don't have good contractility. So if we were thinking about our patient shock in the ICU and we did a bedside ultrasound and saw these images, I would be very concerned that the patient has a much stronger kind of cardiogenic shock component to their shock. And so you can eyeball their right ventricular or left ventricular systolic function. You can look for other causes of shock, like, for example, a pericardial effusion that could be contributing to tamponade physiology or obstructive shock. You can look at their volume status, by example, looking at the inferior vena cava diameter and collapsibility. You can look for valve abnormalities that may be contributing to shock. And then again, as I mentioned before, that volume time integral across the aortic valve can give you an estimate of the cardiac output when you don't have a pulmonary artery catheter. So there's a lot to be gleaned from ultrasound alone. So when we're integrating this hemodynamic data, our goal is to really kind of put all these pieces together, invasive numbers, non-invasive information, physical exam findings, and try to define whether the patient truly has cardiogenic shock and whether they fall into one of these categories, which we'll talk a little bit more about in the next slides, where they may be warm and perfusing well, but they're wet, they're congested, they're volume overloaded. Or are they in that kind of scarier category where the patient has poor perfusion, they're cold on physical exam, and they're not perfusing well, and they're congested. So we can think about how best in each of those categories to make next steps. And then I always encourage people to think about these numbers in the context of what's going on with the patient overall. So we don't always focus on specific numbers, but we do think about kind of what's going on with the patient in front of us and really try to carefully think about and consider what's going on with their physiology and what's deranged, what can we address with our care. So going back to our case, the patient does remain on norepinephrine and vasopressin to support their blood pressure. Their MAP is a bit lower. It's down to 67, so it's at goal, but not kind of elevated as we thought before, where we tried to adjust downwards to improve forward flow. The patient has unfortunately only made about 5 milliliters per hour of urine for the last 4 hours, so the urine output has really dropped off. Their lactate is now rising again. It's up to 7. And so because of these features, a pulmonary artery catheter is placed and shows that the right atrial pressure is 12. The pulmonary artery pressure is 45/32 with a mean of 37. So a patient has some elevation of the pulmonary artery pressures. we find that the pulmonary capillary wedge pressure is 28. You'll remember that our cutoff for normal is 15. So the pulmonary capillary wedge pressure is severely elevated. When we measure the patient's cardiac output by indirect FIC calculation, which is one of the calculations we use to estimate cardiac output, you can see that the cardiac output is 3.2 liters per minute. The index is 1.8, which is severely reduced. And so we're very worried about low cardiac output, contributing to this problem. And we find our calculation, again, measuring the MAP minus the central venous pressure or the right atrial pressure. And then that difference we divide by the cardiac output, multiplied by 80, our systemic vascular resistance is around 13 or 1400. If you remember, the normal range is about 800 to 1200. And so the systemic vascular resistance looks to be increased. So because of the really low cardiac output and because we're really worried about cardiogenic shock, we've decided to add dopamine to our patient, or dobutamine rather, added as an inotrope. And we'll start that at 5 micrograms per kg per minute. So our patient has had worsening shock. We have patients that we see in the ICU with cardiogenic shock. We want to phenotype them so that we can categorize in our minds what's going on with our patient so that we can treat them appropriately. So there are a couple of classification systems. We've talked already about this kind of system, this Forster and Norrie-Stevenson classification, in which we use this kind of 2x2 chart to think about the patient's degree of congestion on the x-axis and then perfusion on the y-axis. So patients who have no congestion and have adequate perfusion are dry and warm. They're well compensated. Patients who have adequate perfusion but have congestion are warm and wet. Patients who are not congested but have decreased perfusion are dry, so they don't have congestion but they're cold. And then the patients that are decompensated and are volume overloaded and have poor perfusion fall in this category. And this categorization system has been used to look at survival for patients moving forward. And you can see that this wet and cold group, labeled as C, has decreased survival compared to the other heart failure groups, even looking forward to 18 months. So you can see that that difference in survival starts early, but then persists late. So certainly this classification system has an impact on outcomes and can be helpful in thinking about our patients. So we've talked through kind of what we think about each of these states, so I won't belabor this, but it can be helpful to put people in these categories in your mind using physical exam findings and using invasive and non-invasive hemodynamic data. We also have the SCAI cardiogenic shock classification system. So we think of this in shock stages. And so the SCAI classifications run A through E. And for patients who are completely hemodynamic stable and not really in kind of cardiogenic shock overtly, they fall into this SCAI stage A. We see some of the hemodynamic parameters and lab values, and also kind of taking into account what type of therapy the patient is receiving down at the bottom here. Those will be relevant as we progress down this pathway. So for patients who are in SCAI stage B shock, we have patients who become hemodynamically unstable, so they're hypotensive. They've started to lose that compensation, but we've not yet started treatment. So we're hopeful that by starting treatment, we can kind of move them back up the flow chart. Patients who show clear signs of overt shock with hypoperfusion, that includes things like elevated lactate, concern about liver congestion or poor perfusion to the liver with elevated liver enzymes, and many other markers of hypoperfusion would fall into this stage C, SCAI shock. And so then we also have D, in which even with initial therapy, the patient is not stabilizing and they still show persistent signs that they're not perfusing well. And then stage E, unfortunately, are the patients who have refractory shock and are simply in extremis, and we're really worried about them progressing to death if we don't intervene. And these will be patients who are requiring multiple drugs, and still, despite the medication interventions that we're providing for their shock, they're showing severe hemodynamic derangements and severe markers that they're not perfusing well. And similar to our other classification system, these are associated with a stratification in mortality. So this is across multiple studies that you see here and looking at the different shock stages. So these are kind of referenced against typically shock stage A, which is not really truly overt cardiogenic shock. But you can see as you move down from B to C to D to E, the in-hospital and 30-day mortality increases significantly. The long-term mortality is also increased for these patients. In some of these categories, as much as 80%, 85%. So really that shock stage E is a really a precarious place for our patients to be. So when we think about management strategies, we want to really think about what are the categories of things that we can do for our patient. We can optimize perfusion, we can relieve congestion, and then we want to really focus on mitigating injury for our patient. And that includes both like the myocardial damage that's being caused by this increased workload, and then balancing that with just the myocardial oxygen supply and demand relationship. So the ACC guidance gives us this nice profile centered way to think about addressing our patients. So this is again back to that 2x2 table of patients who are warm and dry, warm and wet, cold and dry, cold and wet. And you can see this kind of basic framework of how to treat those patients. And so for patients who are perfusing well and do not have volume overload, we're thinking about optimizing their guideline directed medical therapy. They're not going to need like ICU or aggressive inpatient interventions. The profile B, which is that warm and wet categorization, typically because they're perfusing well, they simply need to be decongested with IV diuretics. You could consider vasodilators if like bringing the blood pressure down may be helpful in trying to improve their forward flow and decrease their congestion. For patients who have kind of cold characteristics, you can categorize them by their congestive state. So the ones who are dry and cold, these are patients who actually could potentially benefit from the administration of IV fluids, acknowledging that, as we talked about before, giving increased LV preload may not always increase the cardiac output, but for patients who are truly dry, they may benefit from some volume loading in order to increase their cardiac output. You could also, for patients who are not really responding to additional volume, could try an inotrope, for example, which could be helpful in increasing that cardiac output. And then that profile L, which is that more precarious place for patients who are cold and wet, they will potentially require inotropy. They may require vasopressors because their blood pressure is low and they're congested. They could potentially benefit from vasodilators, which we'll talk about in a moment, and then IV diuretics to try to decongest them as long as you can provide adequate perfusion to the kidneys to remove some of that volume. And then consider mechanical circulatory support for the patients who are most precarious and in those more advanced shock stages. Thinking about those SCAI shock stages again, this is a lot of information on this table, but as you can imagine, the evaluation of our patients for the various shock stages becomes more aggressive as we move down towards SCAI shock stage E. And then our management also kind of focuses on more intense interventions as we move down. So the breakpoint is really around that SCAI shock stage C, where you're starting to think about inotropes, you're really starting to think about whether the patient could potentially benefit from mechanical support. One paradigm in cardiogenic shock management that has been really helpful is the idea of there being a shock team of providers who are well-versed in management of cardiogenic shock at your institution, who could come together and think about whether the patient could be someone who would benefit from mechanical circulatory support versus someone who deserves like kind of more optimization in terms of their medical management. So you would start to think about activating that shock team or really starting to seriously consider mechanical circulatory support at that SCAI shock stage D when they're not responding to medical therapy. And then of course, E is those most sick patients where you're thinking about extracorporeal membrane oxygenation, circulatory support. And then if they're really not turning around despite all interventions, or if they're not a good candidate for some of the interventions that we can provide, thinking about shifting towards end-of-life care. So pharmacotherapy, we have a couple of different categories. I won't focus so much on this because I do think that we have as critical care doctors, a pretty good understanding of these medications and use them frequently, but we have vasodilators that reduce the LV afterload and reduce the systemic blood pressure to try to improve forward flow. We have inotropes, which help to increase the contractility, examples of which include dobutamine and milrinone. And then we also have vasopressors, which increase the mean arterial pressure, they increase our blood pressure. Obviously, that can contribute to increased LV afterload, as we saw in our case that we talked about before. But whenever we are targeting the appropriate targets, and for patients who are hypotensive and need rescue from very low blood pressures, vasopressors can be helpful. So the rationale, again, for vasodilation, as we've talked about throughout this talk with regard to systemic vascular resistance, is that our patients with left ventricular dysfunction can have that excessive systemic vascular resistance that leads them to have poor forward flow. And so vasodilators, things like nitroglycerin and nitroprusside, can be delivered in order to reduce that LV afterload and improve the forward flow from the left ventricle. We have inotropes that include dobutamine and milrinone, are common options where I work. And so we have the dobutamine, which acts on the beta-1 and beta-2 receptors and increases the cardiac output. Because of the beta activity, you can have some reduction in the systemic vascular resistance without any alpha activity to kind of counteract that. So you can have some systemic hypotension in response. Sometimes that can be therapeutic. Milrinone, more commonly we think of actually as a inodilator, where it's providing inotropic effect with an increase in the cardiac output, but can actually reduce the systemic vascular resistance to provide that LV afterload reduction. So the caution with inotropes is that they do have a risk of tachyarrhythmia. And then if you're thinking about myocardial ischemia, whether that's from coronary obstruction or just local tissue ischemia because of poor oxygen delivery and increased oxygen demand, you can have worsening ischemia if you are asking the left ventricular tissue to do more with less. And then lastly, again, vasopressors are the common tools used by intensivists worldwide. And so we think about pressors with inotropic effect. That includes norepinephrine. Epinephrine can be a good pressor to think about using in cardiogenic shock with hypotension. And then dopamine. These are all providing some sympathetic receptor activity. So you can have some beta effect that leads to an increase in your cardiac output, but then also with an increase in that systemic vascular resistance that can improve your hypotension for patients who are really cold and not perfusing well. And then I think it's important for us to think about for managing patients who have cardiogenic shock and have poor cardiac output, there are these pressors that do not have any inotropic effect and actually just increase the systemic vascular resistance in a way that may be not helpful for patients who have left ventricular dysfunction. And so those include, for example, vasopressin and phenylephrine. So when I think about using vasopressors, I usually am thinking with left ventricular dysfunction that I want to try to achieve kind of use the lowest possible dose of whatever pressor I'm using to achieve a map of above 60 to 65 millimeters of mercury. And then I can think about adding inotropes, possibly even vasodilators, to try to address the low cardiac output state of my patient. And as we think about patients who are failing these medical interventions, we have to think about mechanical circulatory support. So those are the patients who fall into that SCI, stage D or E shock. And the triggers for MCS consideration in our mind should be the refractory shock, patients who have worsening end organ function despite our interventions. And then we should be considering this also for patients who just need a lot of medical support in order to support their hemodynamics for cardiogenic shock. So high doses of multiple vasoactive medications. I won't belabor mechanical circulatory support devices because there are a few different options that are available, and different devices are available in different locations worldwide. Some are favored more than others worldwide, kind of depending on local preferences. But the moral of the story with all of these is that you do have some mechanical boost to the left ventricular cardiac output. And that can be through the mechanism of, for example, an intra-aortic balloon pump, which you see in the first column there, where you don't necessarily have a significant increase in the cardiac output, but you do have some unloading of that LV afterload because of the kind of relaxation of that balloon or decompression of that balloon that kind of pulls blood forward during systole. But then you can support the coronary perfusion because the balloon kind of boosts the diastolic or augments the diastolic pressure and can increase coronary perfusion. So in certain situations, patients who have maybe earlier SCAI shock stages, that can be a potential intervention for them that can be helpful. Impella is one of the microaxial pumps that's available. So on a catheter that's placed into the arterial tree, the tip of the catheter is advanced into the ventricle and actually withdraws blood out of the ventricle and ejects it into more proximally on that catheter into the aorta. And so that actually functions to decompress the left ventricle, but also provide a boost in forward flow. And some of these more advanced pumps can actually produce cardiac outputs up to 5 liters. And so you really can support patients who have really pretty minimal cardiac output from their native ventricle. The kind of more advanced end of all of this is vena-arterial extracorporeal membrane oxygenation, or VA ECMO, in which blood is pulled from the venous tree through a venous cannula, which pulls into a pump that's external to the body, is pumped through an oxygenator, which serves as an external lung, and then is pumped back into the arterial tree. And so while this does kind of support the hemodynamics, it's important to note that it does increase the aortic pressure without really decompressing the left ventricle. And so you can increase the LV afterload if you're thinking of how your patient's going to transition and improve their left ventricular function. And so many times in this case, we actually have to provide an additional support device like an Impella to be able to decompress their left ventricle. So we can talk separately about mechanical support devices, but I will leave it there for now. So going back to our case, our patient, despite all of our interventions, remains very oliguric. Their lactate is uptrended to 8.1, and so they are categorized as SCAI class or stage D shock. And so we're worried about them failing their medical interventions. And so we actually take them back to the cath lab where an Impella CP, one of those left ventricular microaxial assist devices where we're withdrawing blood from the left ventricle out into the aorta, was placed so that the patient could be adequately supported. So lastly, monitoring targets in the ICU. So all of the things that we're trying to do for our patient to get them through in their cardiogenic shock as we're thinking about etiologies and how best to advance their care should be focused on these kind of titratable targets. These are values that I like to think about whenever I'm taking care of these patients in the ICU. That includes mean arterial pressure, typically aiming from 60 to 70. And I like to encourage providers in the ICU to think about what arterial pressure, what perfusion pressure is really needed to perfuse the organs. It's less about the specific number, it's more about perfusing the end organs. So sometimes for left ventricular dysfunction, a lower map closer to 60 would be better than in excess of 65. Cardiac index, if you do have the ability to measure from a PA catheter, typically aiming for greater than 2.2, that's really providing adequate perfusion to the organs with oxygen delivery. Central venous pressure, this is one of our measures of filling pressure. If you have a PA catheter, you could also be thinking about what your wedge pressure is. Typically thinking for CVP somewhere in the 8 to 12 range, and then wedge pressure trying to aim for less than 15. And then urine output is, as we talked about before, a nice marker of end organ perfusion. And so if your patient is making urine, they probably are perfusing other end organs as well. And so really aiming to try to maintain that urine output at a higher level so that we can see that the patient's perfusing well. And then lastly, just to give a nod to the fact that our patients, while we're resuscitating them, require a lot of care, but they also do require a lot of thought to de-escalate and to wean support. And so we try to typically wean our vasoactive drugs first if we're thinking about how best to get our patients off. So as we mentioned before, vasopressors are a bit of a double-edged sword. And so if the patient's blood pressure is improving, typically the first thing that I'm looking to reduce is any vasopressor that they're on, rather than jumping to de-escalate from inotropes, for example, first. I would follow clear protocols for weaning mechanical support devices. That's a separate talk in and of itself. But really, as you're kind of trying to reduce the amount of support that they're on in terms of their mechanical pump, looking for a recurrence of that cardiogenic shock, a rise in the lactate, a decrease in the urine output. And then once your patient is stable and off of their ICU interventions, thinking about how best to transition them either back to or onto the initiation of guideline-directed medical therapy, GDMT, for heart failure. That includes a lot of the oral medications that we use for heart failure commonly. In the interest of time, I will kind of move quickly just through kind of future thoughts that we have. But I think as we're thinking about how best to manage these patients, it's an ongoing debate about what is the best time to think about initiating mechanical circulatory support. Is it earlier on when the patient is starting to fail but is not necessarily in that extremis state, or should we kind of spare them the potential complications of mechanical circulatory support early and then kind of shift them to only be cannulated for ECMO, for example, when they're really failing? Hopefully, as we develop more sophisticated technology tools, we can think about what predictive analytics or AI tools we can use to best manage these patients. And then lastly, I really think a lot about, and you should think about too, like how best to individualize the therapy that we provide for cardiogenic shock for our patients. So our summary is listed here. I really want you to think about the physiology of your patient and your patient's left ventricular dysfunction whenever you're taking care of patients who potentially have cardiogenic shock. We really want to individualize our therapy for the patient based on their hemodynamic profile that we obtain through various measures, physical exam, non-invasive testing, and invasive testing. And then the systemic vascular resistance modulation is central. So we want to make sure that their LV afterload, that systemic vascular resistance, is not too high. If it's too high, consider bringing it down. Sometimes in certain situations, we do need to use vasopressors to try to boost the systemic pressure or the systemic vascular resistance. But I would proceed with caution. And then hopefully we'll continue to improve our best practices. So my references are listed here, and I really thank you for your attention throughout this talk, and I hope that this is helpful.
Thank you, Dr. Peck, sir. That was just amazing. Wonderful. So just request you to please stop the share screen.
Yes.
That was indeed remarkable and very nice, and we covered certain areas which are not often covered, the hardcore facts and explanations of cardiac physiology in the ICU. So it was very nice, and I request the audience, if they have any questions, please put up your questions. We will try to answer them. So meanwhile, I can just put up a couple of points for discussion, Dr. Peck, sir. So first of all, is the fundamental question about using vasopressors vis-a-vis what do you call inotropes. You see, most of these patients of classic cardiogenic shock are vasoconstricted with a high SVR, and you want flow rather than pressure building up. So pressure is also important. So how do you? Then literature is very ambiguous, though there is a tilt towards use of earlier inotropes rather than vasopressors. So how do you, what kind of advice can you give us? How to go about this?
That's a great question and something we think about daily at the bedside. So for patients who have cardiogenic shock, as you mentioned, flow is key. And flow is estimated by these end organ perfusion markers. And so many times I think about what's going on with my patient. I try to select what combination of inotropes, vasopressors, potentially vasodilators may be helpful in achieving the goal of end organ perfusion, and trying to fix my hemodynamic targets to achieve that goal. If the patient's not responding, we can adjust based on the response that we're seeing. So if the patient seems to just not be doing well, if you are really just trying to target a specific blood pressure goal with vasopressors, but still they're just not perfusing well, that's where you really would think about whether they could benefit from either changing to a vasopressor that has more inotropic effect, potentially starting a pure inotrope, thinking about whether your blood pressure goal is too high and whether they may benefit from a medication that actually reduces the systemic vascular resistance. So there's a lot of tool and kind of new tooling and nuance in this stage. So it's an important question, but I would always go back to the basic principles and think about what changes you could make to make a positive impact.
Thank you, sir. So the next point that probably you can throw some light on is the extreme vasoconstriction, which can occur sometimes with high dose vasopressors. You can kind of shut off the microcirculation. The SVR is extremely high, and you are increasing the vasopressors, and you can just cause there's a critical closing pressure for the capillaries, microcirculation. So how do you decide here? Do you have some numbers here, or there is risk and the lactate is rising because of that also? And just to give you an example, now we have this early vasopressor used in septic shock. Just going on to septic shock, and how early? Because the capillaries are empty, diastolic pressure is 50. You give vasopressors, early vasopressors, you not filled up the capillaries, and you can just cause a collapse of the microcirculation. So
yeah, it's so tough because obviously we use blood pressure so frequently as a target in our critically ill patients, and we know that they need a perfusing arterial pressure. But what is more important is that microvascular circulation that can be dysfunctional in and of itself in critical illness. And so whenever we have that arterial or squeeze that's cutting off blood flow to the capillaries, those are situations where either trying to reduce the dose of your vasopressor to try to promote forward flow, or thinking about really carefully using a vasodilator and seeing if a lower blood pressure might improve the microvascular circulation. But it is really that fine balance of titrating a perfusing systemic mean arterial pressure to against an increased arteriolar squeeze that's potentially preventing the flow of blood to the capillaries. So I think lactate, end organ perfusion are always great markers. I'm always a fan of thinking about even using capillary refill as a measure, like just even squeezing like the nail beds for your patient and seeing how well circulation returns to the microvascular bed. And then there are even starting to be some kind of imaging tools that some people are using in research settings to look at potentially like under the tongue microvascular imaging, so that you could take a look and see, because the thing that we need to target is microvascular perfusion. And so if we could target some imaging that shows that like sub-Q tissues are being perfused well, that's a great marker.
Thank you so much, Dr. Peck, sir. So then moving on to systemic vascular resistance, I'm very happy you talked a little about it, because this is something people don't talk about very often. But this is an underused number, I think. Can you throw some light? Where do you integrate this number, systemic vascular resistance, more meaningfully?
Yeah, so as we mentioned before, it's a measure that can be calculated at the bedside with a few of our potentially invasive tools. But I think that the systemic vascular resistance can be useful to think about in all shock states, not just cardiogenic shock. And so if you're able to trend it over time, you can see the response to potentially adding vasopressor, whether that's in distributive vasodilatory shock in sepsis or in anaphylaxis, or if for your patient who has cardiogenic shock, you're trying to actually bring that systemic vascular resistance down. So I find it a really useful tool in kind of modifying my therapy and seeing the response of my patient's physiology to therapy. And so whenever I think about the systemic vascular resistance, it is a single point in time. And so it's important for us to kind of compare that number over time. Think of it as something that will respond to interventions that you perform, and then really aiming for that kind of target range where you're not having too much vasoconstriction, not of that low vasoconstrictive state and more vasodilatory shock. We really want to aim for that sweet spot in between.
Thank you so much. Just a final question, sir, and it's getting late now for you also. So this is about the rise of the RA pressure. When the patient goes into acute left ventricular failure, it happens sometimes in the ICU, or the patient comes immediately from home. We have seen that the RA pressure is not always high. There's a lag period. So can you just kind of throw some light on this?
And to clarify, you're referring to the right atrial pressure? Or
yeah. In the setting of acute left ventricular failure, so the pressure starts going up, right? And it starts damming up in the pulmonary circulation. But the RA pressure does not rise immediately. That is our observation, and literature also. Yeah. So can you just throw some light on this? How much can the period be, and what exactly happens?
Yeah, so there certainly can be a decoupling between the right ventricle and the left ventricle function. And in that kind of early cardiogenic shock or early kind of decompensated heart failure, the right ventricle may remain relatively compensated such that the central venous pressure or the right atrial pressure is not yet elevated. And so what you may see is a rise in that left atrial pressure, which transmits to a rise in the pulmonary venous pressure. And these are the states where typically you're seeing more of a pure cardiogenic pulmonary edema picture. And one of the kind of classic states that I can think of, which doesn't necessarily involve left ventricular contractility, but is a patient who develops a flail mitral valve leaflet and develops severe mitral regurgitation. Those patients typically develop flash pulmonary edema. They can have a decrease in their cardiac output, but it's not usually paired with right ventricular failure, at least immediately. So their central venous pressure, their right atrial pressure may not go up significantly, but they can have florid cardiogenic pulmonary edema because of that rise in the left atrial pressure and that congestion of the lungs. So that is one specific example, but that certainly can apply also for our patients who have left ventricular failure who don't yet experience right ventricular failure as a result.
Great, sir, great. Dr. Peck, sir, that was wonderful. It was highly interesting, highly educative, and you touched on various aspects of LV physiology, systemic vascular resistance, and we had a very large audience and people there on YouTube, and it's being recorded. And soon we shall put it up on our YouTube channel and shall share the recording with you. Thank you so much, sir. Take care. Bye-bye. Good night.
Very good. Thank you.
Thank the audience for joining in so much. Namaskar. Hi and goodbye. Thank you very much.